All right, good afternoon, everybody. Hi, this is Mark Blattner with the Jewish Federation, and we are delighted to bring to you the start of our weekly Wednesday series that we're going to be doing. Our first conversation today was with Dr. Lynne Strasfeld, who I will introduce in just one second. But our hope is that every Wednesday at some point in time, some days will be at 4 o'clock, other times it might be at a different time period. We hope to bring you some things of interest. Next week, we'll have several organizational executive directors talk about how the pandemic has impacted them. On May the 6th, we'll have Senator Jeff Merkley come and speak. And on May the 13th, we were just able to confirm Senator Ron Wyden to come and participate in one of these calls. So we're grateful that you're here. Two things that I want to emphasize about today's call is, first of all, we're grateful for Dr. Strasfeld's not only expertise, but also her time. And I know she's put together a presentation for all of us. But number two is we hope that you'll utilize the chat function to ask questions. So if you can please make sure that you enter questions into the chat. We'll be reviewing those as Dr. Strasfeld goes. And as we get closer to the end of her presentation, we'll be able to ask questions in an appropriate way. I'm sure many of us have questions that are the same. So without further ado, let me just welcome Dr. Strasfeld, who is the Associate Professor of Medicine and Program Director at OHSU's Infectious Disease Fellowship Division. She received her undergraduate degree from Cornell University and a doctorate in medicine from Yale School of Medicine in 1996. And we are honored to have you here and grateful to have you in our community. So Dr. Strasfeld, I'll turn it over to you.
Thank you. And thanks for the kind introduction, Mark. And really, it's an honor for me to be able to present. So what I will present today will be a COVID-19 update, and I'll provide some background and hopefully address some of the questions you have. But just as Mark advised, if you do have questions that you want to reach me about, just type in, and hoping at the end we'll have time to get to that. And I think I have either Wendy or Mark to thank for this title, Flattening the Curve in the State of Oregon. Some disclaimers to start with. Although I work at OHSU in the Division of Infectious Diseases, I'm not speaking on behalf of OHSU. I'm not an authority on COVID, although I'm an infectious disease doctor. I am a member of Neve Shalom, and I am a Jewish mother. So keep all those in mind. So just the timeline maybe will serve as a nice introduction to our discussion. So this is a picture of my kids, Margot and Anderson, at the Moda Center on February 25th. And you could see it's a full stadium. And we saw the Blazers lose to the Celtics that night, so late February. And then this was March 12th. And, you know, maybe not such a landmark in your home, but in our home, this was big. So NBA season was canceled rather abruptly while the players were on the court. And then there was talk of the Olympics and would they happen with social distancing. And just like so much else, the Olympics have been canceled. So in the course of a short month, I think this is an analogy for how all of our worlds really changed dramatically. So how did we get here? A little background. So this is one of the Sentinel papers on describing COVID-19 as it's now known from the Wuhan outbreak in China. And so this is a timeline, and what you can see here is that there was a clustering of pneumonia cases that occurred throughout December, and they were felt to be in association with the seafood market there. So the seafood market was closed, and very soon after, which is really remarkable, COVID-19 was identified roughly a few weeks later. And then things really took off from here. We know that Wuhan City shut down at the end of January, and WHO declared a public health emergency on January 30th. And so it was in February that WHO designated the disease caused by the SARS coronavirus 2 to be COVID-19. So we're talking about the disease caused by the coronavirus. And WHO declared a pandemic on March 11th, 2020. and WHO infrequently declares a pandemic. And as of today, though I keep updating my slides, there are over 2.5 million confirmed cases worldwide. Very little bit about virology and the origins of this virus. It's an RNA virus, and it has an envelope. And the origin is either from this bat or this pangolin, Malayan pangolin. Based on the phylogeny, folks are leaning towards the bat, which is kind of a shame because the pangolin is kind of cute, I think. And then it's thought that natural selection occurred in humans after the virus jumped to humans, or zoonotic transfer, if you will. So it's not exactly the same virus that they found in bats, and that's probably because of some genetic changes that occurred once it adapted to the human host. The clinical course, in the first week, patients with COVID-19 experience fever, dry cough, sore throat, loss of smell or taste, head and body aches. And then it's in the second week when the disease in those who are symptomatic can at times be more severe, with shortness of breath and pneumonia and multi-system illness. So this is a nice diagram. And we're learning more about COVID-19 disease at a rapid pace. And what we're learning is that it really leaves no part of the body untouched, if you will. So there are some neurologic effects that we're learning about, cardiac disease, kidney disease, etc. And something very particular about this is what I mentioned, the anosmia, or the loss of smell or taste. So the epidemiology is interesting. That's what you see in the papers when you open them. How many people have been diagnosed with COVID-19? And so this is a website that's updated numerous times a day from Johns Hopkins. And as of just a few hours ago, there were over 2.6 million people in the world with COVID and 182,000 deaths. And over here, what you can see is that we're still on the upswing, if you will, of diagnoses. What does COVID look like, the epidemiology here in Oregon? There's a weekly report that our health division, the Oregon Health Authority, publishes each week, published yesterday. And what this shows us that as of counting for this, there were 19,028 cases of COVID. And what you can see here with the breakdown by age is that they occurred in a wide variety of age groups, but that deaths and hospitalizations really focused in the group that was 60 and older in Oregon. And so of the cases that we had as of the time this report was put together, the 1,928, for those that we had data on, the blue are yes and the peach are no. A third had contacts with the confirmed case. 20% or so lived in congregate living, so assisted living facility or other congregate living. 17% overall were healthcare workers, but I would interpret that with a grain of salt, because healthcare workers are perhaps more likely to get tested. And of those healthcare workers that had COVID, the majority had direct patient care responsibilities. And a third of those diagnosed in Oregon have had underlying conditions, and I'll talk more about underlying conditions later on. So how does this virus spread? So it's mainly person to person by respiratory droplets, and this figure is here to show you that respiratory droplets are a lot larger than aerosols. And this is the main mechanism of spread. They're 0.1 and compared to aerosols, which are less than 10 micromolar. So they're a lot bigger. And it's possible that the virus is also spread from contacts with contaminated surface or objects. So objects that are within this spray, when somebody coughs or sneezes and get contaminated, that's how COVID spreads predominantly. But there are other routes, and it is described and accepted now that there are folks who are asymptomatic carriers who can spread COVID, and their period of infectivity isn't yet known. And then also airborne spread through these aerosols. And why this is an important distinction is because this tells you what the risks are. And really this is critical in the healthcare setting, where we think about diseases that spread by droplets, so larger particles, relating to direct contact or contact with indirect contact, contact with an object that a patient has touched. Whereas aerosols may contaminate a room, and there's transmission through what we call aerosol generating procedures. So different procedures that patients have in the hospital. And then a little bit more, this is the one, if you'll grant me, epidemiology background or lesson that I'll go over for you. This is the R0, or the basic reproductive number. And this is really critical when we think about how diseases spread, their epidemiology, and how they take off in our populations. So the R0 is new cases over existing cases. And so here's an example. The existing cases are the orange dots, and the new cases are the red dots here. And what you can see for COVID-19 is that for every one existing case, the R0 currently is about 2.2 new cases. So this disease is spreading, and that's why we're on the upslope still, if you will. It's more infectious than influenza, but it's substantially less infectious than measles and smallpox. And so there are factors that mitigate or increase risk for transmission, and here they are described. So it's the risk of transmission per contact, like the attack rate, which is dependent on the type of organism or infectious particle that you're talking about. The average number of contacts that the individual who has the infection has, and then the mean duration of infectiousness. So all of these factors impact the R0, and how successful a virus is in spreading is a function of its R0. The higher the R0, the more likely spread is to continue. And to control an outbreak, which is what we'll talk about now, the effective R0 must be less than 1. So how can we reduce our effective R0 to less than 1? So we can do a number of things that we've taken on as a country and as a state. We can identify and isolate cases to decrease the number of contacts and decrease probability of transmission. We can encourage hand hygiene, so hand washing, masking. We can quarantine contacts, and we can take on social distancing, as we all have in the past few weeks. And so this is the rationale behind the national campaign, 30 Days to Slow the Spread. So to really avoid social gathering, try to work from home, avoid discretionary travel, and practice good hygiene. And so how was this incorporated in Oregon? So over the course of really what is laid out here is 2 weeks, which is unbelievable. Initially March 7th, our governor declared an emergency due to the coronavirus outbreak, and subsequently went on limiting visitors to long-term care, prohibiting large gatherings, and that effectively closed schools on March 12th. Prohibiting on-premise consumption of food or drink, so closing restaurants. School closures officially, and other school-based and child care services on the 17th. Conserving PPE, or personal protective equipment, in hospital beds for tending to the COVID crisis, which postponed all non-urgent healthcare procedures. And then the Stay Home, Save Lives order, which you're all familiar with, from March 23rd. And so the rationale behind all of these measures was flattening the curve. And I'm sure that many or most have heard that term. And I want to explain why that's important and what flattening the curve is. So it's not really decreasing the number of infections over time. It's more spacing them out and hoping and endeavoring that the number of cases won't ever exceed our healthcare system capacity here, so that the curve becomes broader and flatter, but it doesn't go away, and I'll get back to that. And we learned a lot about flattening the curve from Italy, and even in Wuhan in the early days of the outbreak, where the number of cases unfortunately overwhelmed healthcare capacity, and mortalities were much higher than they have been in other scenarios where we've been able and folks have been able to flatten the curve. So the mortality in Italy still stands over 10%, roughly 13%, because their hospitals were so overwhelmed that they couldn't appropriately deal with the cases, is the thinking. And so here are some projections from Oregon, and this is, I think, really interesting to look at now a month hence. So these projections were published on March 30th. And what you can see here is that this is what was projected on March 30th. If we continued the current conditions, which essentially we have since that time with social distancing, you can see this leveling off here of active infections and cumulative infections. So here's where it leveled off. Whereas if we return to March 12th and business is open, the projection was that we'd continue to see an uptick in active infections. And so here's what we arrived at, and this is as of yesterday morning. And what you can see here is that we as Oregonians have successfully flattened the curve. The most up-to-date figures tell us that we've had 2,002 cases, and of those, 471 required hospitalization for those whose status is known. And our cases really are tapering off here. So that's good news. So going forward, and I'm going to talk to you about why this is all still very relevant. How do you protect yourself and protect others from COVID, from acquiring COVID? So stay home or call your doctor if you're sick. I like the term physical distancing a little better than social distancing, because it's the physical piece that we're looking to separate to decrease transmission. And we're learning to network socially in different ways, just as this webinar today. Hand hygiene is so important. As I said, this is a disease primarily spread by droplets, either direct from touching somebody who has COVID, or indirect by touching something somebody who has COVID touched. So hand hygiene is critical. And to that end, also cleaning and disinfecting frequently touched surfaces. And then masks or face coverings, which I'll talk a little more about. So why should I wear a mask, and what kind of mask do I need? So the reason to wear a mask is simply if you happen to be, you as the mask wearer, infected and have no symptoms or mild symptoms, and you're out and about, which if you have mild symptoms, you shouldn't be out and about, but let's say you're asymptomatic and you're wearing a mask, you're less likely to transmit to somebody else. So you're wearing a mask for the protection of your neighbors, your friends, your family. You're also wearing a mask, and this can't be understated, because it's a good prompt to remind you to not touch your nose and your mouth and your face in general, because those are, that's often how we acquire COVID. So we'll have a droplet or a foam mite on our hands, and then touch a mucous membrane, and that's the route of transmission, and then infection takes hold. It's healthcare workers that are wearing masks to protect them from other patients who are infected when you think about healthcare grade masks. So there's a subtle difference there, but CDC has asked everybody to wear masks. when you can't social distance in particular. And there are a lot of resources these days available. These web links are live. New York Times and CDC on how to construct a mask. Okay, what's my chance of getting COVID? So it's based on your time and intensity of exposure. So we've learned that from the various outbreaks that have been described, congregate settings, folks aboard a ship, folks in subacute nursing facilities, based on their time and their intensity of exposure are higher risk, whereas fleeting interactions with folks who aren't symptomatic are of lower risk, we think, for transmission. And so when you think about what your risk is, you have to think about where you are, because we're not traveling now. So we're here in Oregon, and as I said, we've had 2,000 cases to date, and our case rate is relatively low when looking at the country as a whole. So here in Oregon, at least at this current time, our risk of getting COVID is lower than it is elsewhere, provided we continue with the measures that are in place. And what everybody wants to know, so if I do get COVID, how sick will I get? And so we have data from China that informs this, and then also some emerging data from our own country and our experience. So this is data from 72,000 cases. And what you can see here is that the patients who were diagnosed were largely between 30 and 79 years of age. Which doesn't tell us all that much. The spectrum of disease for all comers, and this provides some reassurance, was mild in roughly 80%, but severe in 14%, and critical, requiring ICU care and intubation in 5%, or a breathing tube put down. The case fatality rate, so how many of these patients who got COVID died, overall of the 72,000, there was a 2.3% case fatality rate. And the case fatality rate was higher in those at extremes of age. Those who were greater than 80 years old had a nearly 15% fatality rate. 8% of the deaths were in, the case fatality rate was 8% in those in their 70s. And when they looked at all deaths in this large series of patients, roughly 80% occurred in those who were greater than or equal to 60 years of age. And of those who had critical illness, like I said, those who needed a breathing tube put down, the mortality rate was nearly 50%. So very sobering. And here, this is some data that we have, at least as of March 18th, of 4,226 cases that were reported to CDC. And what you can see here is that the age distribution is broad. So we have almost just as many patients admitted in their 50s and 60s and 40s as we do at the other end of the spectrum, and perhaps more so. But the disease was not as severe in those who were younger, though there were still a sizable number of intensive care unit admissions in folks in the 20 to 44 age group. So which people are at higher risk for severe illness due to COVID? It's those, as I said, who are older, and CDC segregates that at greater than or equal to 65 years of age. People who live in a nursing home or long-term care facility have had worser outcomes. And then people with a variety of underlying medical conditions, particularly if those conditions aren't well controlled. This list, I don't intend it to be exhaustive, but are some of the representative problems that folks who've had bad outcomes with COVID have had, as you can see here. So another question you might have, I've heard that some people with COVID don't have any symptoms. Is that true? And it is true. So asymptomatic infection does occur. there are a lot of unknowns here. There are multiple studies, closed settings, if you will, like a cruise ship or a skilled nursing facility, that show a non-zero rate of detection of SARS-CoV-2 in patients who don't have and never go on to develop symptoms. So when everybody in a population is tested, there are going to be patients who have a severe presentation, and it often but not always segregates with age and comorbidities. And then there are going to be patients who have infection and have no symptoms at all. And this is actually something that I want to emphasize here. We call all patients who have the disease the denominator or denominator data. And it has really important implications for how we classify disease severity and mortality rates. So right now, we're talking about mortality based on the patients that are diagnosed, but the patients that are diagnosed may not represent the true complete universe of patients who are infected, okay? So it's in the context of an evolving outbreak, as we have, there's always an exaggeration of disease severity and mortality just for that reason. So what treatments are available for COVID? I grayed out hydroxychloroquine here. Suspect some of you have read about it in the news. So this is a drug used to treat malaria. It has some potentially serious side effects, cardiac effects, and its benefit is increasingly questioned in this population. Remdesivir is an investigational antiviral. As of now, it's only available by IV or intravenous formulation. A number of the hospitals in the Portland metropolitan area have access to remdesivir on study. What we have from the data we have is uncontrolled, meaning it's groups of patients who received remdesivir, but there's no comparison population who didn't. And the initial results are perhaps promising, but we certainly need more data, more robust data, and controlled data. Quite a bit of the severe disease attributed to COVID is felt to relate to an overexuberant or very robust immune response. And so there has been interest in looking at immune modulating agents or medications that dampen the host immune system as potential agents to decrease disease severity. And again, those are under investigation. Most notably, steroids are not beneficial. And we learned that from the experience in China. And then lastly, there is interest in convalescent antibodies or plasma therapy. And I'll refer back to this at the end of the presentation. But what this is essentially is it's collecting plasma from individuals who have had COVID and have cleared the infection, but have antibodies, and then transferring those antibodies to patients who are ill with COVID. Okay, some more basic questions. Do I need to wash my groceries? Here's my opinion. No, I don't think so. There's no evidence that food or food packaging has been linked to getting sick from COVID, and that's according to CDC. But it is recommended that you use hand sanitizer when you leave the store and wash your hands when you get home, because really it's the contact that you'd have at a grocery store. And of course, also wearing a mask if you're in the grocery store and or social distancing. And then ordering online or using curbside pickup is an option to decrease your contacts, your direct contacts, and therefore decrease your risk of acquisition. All right, this got cut off here, sorry. So do I need to worry about my dog? If you could just allow me, this is our new pup. So this is Sadie, our golden doodle, mostly golden retriever. And then we have brought home a new puppy, a Labradoodle, Leo here. So is there concern about dogs getting COVID or acting as vectors, so transmitting COVID to people? So there's no evidence suggesting that domesticated animals are a major source of infection in humans, and no reports of transmission of SARS-CoV-2, the agent that causes COVID-19, no reports of transmission from dogs to humans or other animals for that matter. There are rare reports of animals who have acquired, we think, SARS-CoV-2 from individuals, from humans who have been symptomatic with COVID. There are 2 dogs and I think 1 cat and then a tiger at the Bronx Zoo that have acquired COVID from contact with symptomatic humans. And with the tiger, I don't know what the story was, if he was, within 6 feet of the handler who was later found to have COVID, but no documented transmissions in the opposite direction, so animal to human. So CDC recommends people with confirmed or suspected COVID-19 try to avoid close contact with household pets. What if I need to go to the doctor for another reason? So as I outlined, based on Governor Brown's orders, non-urgent surgeries were canceled and a lot of non-urgent visits to healthcare have been canceled or rescheduled. And so there are options. Myself, I've been doing more telemedicine than I can really believe relative to where we were 2 months ago. And I would say that it's a wonderful way to interact with patients if there isn't necessity of it in-person evaluation. And sometimes there is. Rescheduling if it's not an urgent visit or procedure. But what I do want to emphasize here and put it in bold is that if you need in-person care, you should seek in-person care in the safest way possible, calling ahead if possible, wearing a mask if possible. And if you need emergency care, you should go to the emergency room. We've seen all across the board a decrease in hospitalizations and presentations in the outpatient setting, fewer MIs, fewer strokes, fewer other complications. And the nagging concern is that folks are having medical conditions at home and not seeking care out of fear. And what I would say is that I feel quite comfortable, at least at the institution where I work at OHSU, and in speaking with colleagues at other hospitals in Portland, that we're quite prepared. And if in-person care is required, that you should feel comfortable seeking it. All right, some other questions that maybe you're thinking about. When will my kids go back to school? What should I plan on for this summer? So opening up America again, this is the government's response and I would say guidelines to states on when they can reopen. And so there are what they call gating criteria to consider reopening and entering phase 1, which I'll speak a little bit about. And those gating criteria include downward trajectory in new cases, that the healthcare system has surge capacity so that if cases increase, there's the ability to take care of patients appropriately. And then this is a big one, testing and contact tracing ability. So having the public health infrastructure to diagnose a case in the community and investigate the contacts of that case and test them and then quarantine them as indicated. So I feel like criteria 1 and 2 are in place when I think about Oregon, but I'm not entirely convinced that we're there yet on the third count. And predicated on this gating criteria is continuation of hygiene and masking and social distancing, etc. So when in Oregon and elsewhere in other states, we and they are ready to open up. This is the guideline that the government has provided to states that in phase 1, vulnerable individuals, and those would be individuals at higher risk for bad outcomes with COVID, continue to shelter in place. That all of us avoid social settings of more than 10 people if we cannot physically distance, which means schools remain closed. That telework is still encouraged, that we minimize non-essential travel, and large venues can reopen with strict physical distancing. So maybe the NBA plays, but there are no fans in the audience. And then elective surgeries can be resumed. Phase 2, if phase 1 goes well and there are no backslides and no increase in cases, phase 2 can be entered. And in phase 2, the guideline is to avoid social settings of more than 50 people. If you can't physical distance, this would allow schools to reopen, and schools would look a little different. So the desks would be further apart, and there would be a variety of accommodations one would envision. Non-essential travel can resume here. And then phase 3, if over time phase 2 goes well, phase 3 looks like vulnerable individuals resuming public interactions, but with physical distancing and masking, that more people can get back to the workplace, and that large venues can operate with limited distancing, limited physical distancing. So over time, what about next year? And the question on many of your minds, will we be able to go on the Federation trip to Israel next March? So looking out into the future. And so this is where I want to reflect and offer some concepts to think about. The phases, phase 1, phase 2, phase 3, are unlikely to be linear. So we could enter phase 1 and then things look good and we enter phase 2, and then the infections return and we're back to phase 1. And the phases are unlikely to be uniform across the country, because as we know, each state is dealing with a different trajectory of illness, a different peak, and a different incidence rate of infection. And so I want to go back to this curve, this flattening the curve and time since first case. And the goal is to stay within the healthcare system capacity so that we can take care of patients who happen to develop COVID, because this isn't going away in the short run, and ensure optimal outcomes, so not duplicate the scenario that was seen in Northern Italy. And so I drew this. This is what it might look like for our state. So once we open up, we might see an increase in infections, and then we go back and slide back and our social distancing again, and teleworking exclusively. And then we phase into phase 1 and phase 2. See the incidence of infections creep up again. And because we have a robust public health infrastructure, those folks are able to test and to isolate and then ameliorate our case counts. And it goes on and on here. And I really like this analogy, a lot of sports analogies. I'm not such a huge sports fan, but Mike Osterholm is an epidemiologist from University of Minnesota and is a super smart guy. And this is an article that I read in the lay press from CNN, and he's cited as saying, we're only in the second inning of the pandemic. So when we look at these curves, it may give and provide the misconception that we're going to get down to 0 and this will be done. And unfortunately, I believe that we'll be living with this virus for some time. Okay, more questions. Can my daughter or son have their bat mitzvah in? And so, you know, despite the fact that we'll have these peaks and troughs and fits and starts of the virus, I'll put forward that we will be able to resume activities, and specifically activities like this with accommodations. And this is a screenshot from Lily Crow's bat mitzvah from Neva Shalom. Here's Lily with Rabbi Kozak this past weekend. My family and I watched from our breakfast table. And Lily did just an outstanding job. Mazel tov to her and to her family. And with their permission, I'm using this picture. And what you can see here is an adaptation. So she was able to have her bat mitzvah, but there were, I believe, 9 people in total in attendance physically, but remotely there were numerous people in attendance. And some of the rituals were modified to ensure safety, but it didn't decrease the joy that Lily, her family, and all of us took in this event. So over time, it'll be adapting to the new normal and approaching it with flexibility and with accommodations. Okay, wrapping up soon. So how and when will this end? This is how it's going to end. So either we're going to have herd immunity, and I'll talk to you about herd immunity, and if you'll allow me, I'll get back to a quick lesson in epidemiology, or we get a vaccine. And so remember the effective R naught, or the R naught was the number of new cases over the number of existing cases. The effective reproductive number, the R, is the R naught multiplied by X, which is the proportion of the population that remains susceptible. So if you have, let's say X is 10%, because you have a really good vaccine, 90% of people are vaccinated. What you see is that the R naught, which is 2.2, we said for COVID, multiplied by 0.1 is going to be far less than 1 if you can have a high proportion of the population that is immune, either through natural infection or through vaccination. So, like I said, with COVID, the R naught is 2.2, and for control to be effective, we would need 50 to 60% of people to be non-susceptible, either immune through natural infection or vaccinated. Because if we take 1 minus 1 over 2.2, we get 50 to 60%. Okay, so, and what I would say about vaccine, I don't know a whole lot more than you know in reading the popular press and listening to health policy pundits, but the projections for the timeline of an effective vaccine in hand to deliver to people is estimated to be around 18 months. The fastest development and deployment of vaccination on record so far is mumps, and that was 4 years, though that's a number of years ago, and thankfully medical technology is advanced. But I don't believe that we'll have a vaccine in hands in the next year. So the unknowns, the true disease severity and mortality rate is unknown. Just like I said, we don't know the true universe of people who are infected. The asymptomatic folks will increase the denominator and decrease disease severity and mortality rate when we look at this outbreak in retrospect. We don't know the durability of immunity. So if somebody develops COVID and has COVID and then develops antibodies, we don't know if that'll protect them for life or for a couple years. We're learning as this evolves. Antibody testing, I figured might come up as a question. So the FDA has approved antibody tests, and antibodies are our body's response to an infection, and they are long lasting, but we don't know when we do antibody tests how specific they are for this particular coronavirus, and whether a positive antibody test on somebody's labs will be a good surrogate for functional immunity, meaning you're protected. We don't know about the impact of mutations in the virus. So what would increase the fitness of the virus if the virus became a less severe disease? But there is unfortunately no indication as of yet early in the outbreak that that's happening. And I'm interested in what the impact of mutations in the virus, the implications are for vaccine development, and time will tell there. And then, of course, and I'll attribute here appropriately, the unknown unknowns, which we can't predict. So wrapping up here, I'm sure all of you are thinking, what can I do to help? Comply with the stay-at-home orders, physical distance when you do go out, mask in public, remember that's to protect your friends, your family, your neighbor. If you've had COVID, the Red Cross is looking for folks who have recovered for plasma donation. Remember, I referred to that as a potential therapeutic. And then help your neighbor. And that could be, you know, obtaining groceries for somebody who's in a vulnerable population. It could also be picking up the phone and calling. So if you'll allow me a moment to reflect, I've seen some things in the past 2 months that I thought I'd never really see. And here are some clips that I found a little bit humorous. And then for the sports fans in the audience and in my home, competitive marble racing is a thing, or at least now that we don't have NBA and other sports. Before I finish, there are some silver linings here. So after 30 years, the Himalayas are visible from India, which is beautiful. And the decrease in fuel emissions has had a positive short-term effect on our environment. And then I also found this article, which I liked a lot. So I'll wrap up there, and if there are any questions from the remote audience, I would be delighted to address them.
Okay, so Dr. Strasfeld, first of all, thank you very much for your very comprehensive and very interesting and I'll say understandable presentation. So thank you. I've been topping down all the questions that people have been asking. So what I'd like to do is just do it in rapid fire with you, Dr. Strasfeld. So
sure thing.
You can give one-word answers, two-sentence answers, or whatever, but we're just going to kind of go through and hopefully capture all of them, especially the ones that you did not answer as you went through your presentation.
Okay.
Theory that this was founded in a Chinese lab, true or false?
I'm going to bet false. I'm going to bet false. But there is a lot we don't know.
Okay. At what point it's of someone who had COVID-19, at what point are they no longer contagious?
I would say somewhere after 10 to 21 days. So when folks have had COVID, they've been able to recover live and infectious virus anywhere up to 10 days, and in folks who have had severe illness, as long as 21 days and perhaps a bit longer. And it seems to co-segregate with disease severity, how long you have virus recoverable.
Great. How safe are childcare facilities, especially for children under the age of 6?
Well, I guess that's a multi-part question. So if there's one blessing in this pandemic, it's that young children don't seem particularly susceptible to severe infection with COVID. For the child in childcare, I would say it's not as much of a grave concern, but then those child's contacts, so do they have close contacts with a vulnerable person or somebody in one of the groups that would do poorly with COVID? And that's where the concern is.
Great. How do we get people to understand that flattening the curve does not mean that the pandemic is over?
Smart people like Mike Osterholm in the media, but that is an important misconception to correct.
Yes, great. If I've sheltered in place for 3 weeks or more, and so have my friends, and nobody has symptoms, why can't we get together?
Well, so I did say that there are folks that are asymptomatic and infected, and they can be a vector for spread. And, you know, how well do you know what your friends have been up to?
Okay.
And then also, so our governor is asking us not to do that.
Right. Fair enough. Is there a projected timeline for everyone to be able to get tested as well as antibody testing?
No. So that's, I like that question. So there are studies now. Antibody testing is going to be complicated, I think. Like I said, there is an FDA approved test. So your doctor conceivably can order an antibody test. But I fear that the implications and the next step from the result on the antibody test may be misconstrued. So we don't know that it's specific for COVID-19 if it is positive. And if it is positive, we don't know that it is associated with your being non-susceptible or immune. So I think right now there are a number of studies, a number of them have targeted healthcare workers because of the frequency of their exposure to COVID. They're at higher risk, and doing serial antibody testing on them. And if they are positive on antibodies, do they subsequently have protection from new infection?
Great. I know we don't have a timeline of when we can all go back to normal activities, et cetera. Do you think that older people who are immunocompromised will have to wait even longer to get back to their regular activities?
Unfortunately, I do.
Okay.
With,
Yeah. Okay. What do you know about the study that was done in Los Angeles? It was reported in the LA Times that 4 to 5.5% of the people there are infected.
I saw that. Again, it goes back to the specificity of antibodies. So SARS-CoV-2 is a coronavirus, and there are other coronaviruses. So until we actually have more data, and I don't know that the LA Times is where I'd get my scientific data, we have to be rather circumspect about believing that actually is representative of immunity to COVID-19.
The CDC director shared yesterday that we will most likely see a spike in infections this winter, both COVID-19 and flu. What can you say about that?
I think that's probably true. I think we'll see a spike in infections when we loosen up our stay-at-home orders too. Okay. So it's going to be reliant on us having a nimble public health infrastructure such that the peaks don't surpass our ability to take care of patients appropriately.
Great. What do you know about vitamin C IV drips that were used as a treatment in China?
I don't know.
Okay. What's the difference between aerosol and droplet transmission?
Yeah, okay, thank you. So droplet transmission are larger particles. They don't stay suspended in air. Actually, I thought that I might not have been clear. So is that showing up? So these are large droplets, and they will fall to the ground because they're heavier, if you will. So they're not going to remain suspended in air. So the way somebody, if a disease is spread by the droplet route, it's either somebody like coughs right on you, and then you use your hand to wipe your nose, and then you develop infection, or they cough all over your keyboard, you touch your keyboard, and then you touch your nose and you have infection. So aerosols are different. They're smaller and they're lighter, so they can stay suspended in air. So the postulation is that occupying the airspace of somebody who had left the room but had had COVID is a theoretical risk for acquiring infection. And I would say that this is most relevant in the healthcare setting where we do aerosol generating procedures, like patients have a breathing tube inserted and that generates aerosols. So that's why the healthcare setting focuses more on this distinction and this risk than the community setting. And thank you for that question.
Great. I wear my mask outside. Do I need to wash it every time I come back?
I don't think so.
Okay. You mentioned about a downward trajectory.
But can I get back to that? So,
yeah, sure,
so the mask, you know, like we don't have good efficacy data on, you know, homemade handkerchief masks. So what they really are, like I said, preventing you from spreading infection if you're asymptomatic or post-symptomatic, and also as a guide for you to not touch your face with your hands. So if it's soiled or wet, I would wash it. Just use good common sense.
Great. Just a few more questions.
Yeah.
Downward trajectory. How many consecutive days do we need to see before we have a reliable trend?
So 14 is what the government defined for us, and that's COVID infections, like documented infections, but also like a syndromic surveillance, so fewer admissions and presentations to the emergency room with upper respiratory symptoms. That also needs to track down, because as we know, we've lagged a little in testing and nationally, and we haven't made all the diagnoses that are out there.
How long does the virus remain on surfaces, whether it's a cereal box, lawn materials, cleaning supplies, etc.?
Yeah, so this one here I have. So this was an article. You know, I thought I'd get this question, which is why I have this slide. This was a New England Journal article from last month. And it is possible that it can remain on surfaces in viable titer or quantity for up to a day and maybe longer.
Great. All right, thank you. Beyond this CDC, where else can I get reliable and relevant information?
The Oregon Health Authority, their website is nice. Yeah.
Okay. In the list of predisposing factors that you presented, you did not mention hypertension. Is hypertension an issue?
So I would say it's the studies that have pointed at hypertension have implicated patients who have poorly controlled hypertension.
Great. What's the impact of the temperature and humidity on COVID-19? So if it's warmer for the summer or if it's colder in the winter, what's the impact on the virus?
Many of the circulating community respiratory viruses do dissipate in the summer. The unfortunate situation is that Australia's had a heck of a time with coronavirus, and there's a lot of disease activity in Florida now. So I think we would be wrong to assume it's going to die out in the summer.
Great. Last question. You mentioned this earlier, I think, but takeout food, you think takeout food is okay? Or you don't think it's okay? Yes.
I think it's okay. I think it's okay. I mean, it's your interactions. I think takeout food is okay.
Okay. Last question,
Yes.
and then we'll wrap up because this has been great. Thank you. Is there a way to look at Oregon COVID-19 case by case on the zip codes?
Not that I know of. By county, there is actually.
By county.
The Oregon Health Authority has disease incidence by county and deaths by county.
Great. Dr. Strasfeld, thank you very much for the presentation, for the information, etc. I appreciated it. I understood it. That was even better and more important. And I'm glad that we had over 350 people from the community join us to hear your presentation. So we're delighted by that. And I also just want to add that our next presentation is going to be next week. It's at 2:00 p.m. on Wednesday with several Jewish organizational executive directors who are going to share their stories of what they're seeing in their own organizations and agencies and synagogues. So Dr. Strasfeld, any last words you'd like to share?
No, it's an honor to be able to present, and I'm grateful. And I hope everybody is well and stays well.
We hope everybody stays healthy and well. And thank you again. And we appreciate it. Thank you very much, everybody.
All right. Bye-bye.
Bye-bye.